Welcome back, everyone, to Webinar 4 in the Evidence-Based Pediatric ME CFS webinar series by Dr. Peter Rowe. This webinar is Biomechanical Considerations of Pediatric ME CFS. Here, we hope to continue pulling it all together for you. As noted, Ehlers-Danlos Syndrome and hypermobility syndromes often coexist with myalgic encephalomyelitis. Orthostatic intolerance and structural dysfunctions should also be considered in pediatric ME/CFS cases. By biomechanical considerations, we mean, in Rowe's words, symptoms that can be provoked by application of a nerve or neural strain to the limb or to the spine. This webinar delves more deeply into neurogenic thoracic outlet syndrome. I am Bridget Collins, Chair of MEAction Maryland. At MEAction Maryland, we support our community, advocate for change, and create medical education. We began our webinar series because the preponderance of chapter members who have pediatric onset, combined with the dearth of materials on pediatric ME. And with that, I'll let Dr. Peter Rowe of Johns Hopkins Children's Center, inaugural recipient of the Sunshine Natural Wellbeing Foundation Endowed Chair in Chronic Fatigue and Related Disorders, take it away. Here's Dr. Rowe.
Well, hello, I'm Peter Rowe. I'm a professor of pediatrics at Johns Hopkins and the director of the ME/CFS clinic at the Children's Center. In today's webinar, we're going to talk about biomechanical considerations in pediatric ME/CFS. And biomechanical just is a jargony term, but we're going to break that down so that you've got a good understanding of what we mean. This is a relatively neglected area by many ME/CFS practitioners, but we think it's a very important way to begin treatment and to improve the individual's level of activity. So the outline for today's talk is here. We're going to look at the fact that joint hypermobility and Ehlers-Danlos Syndrome, which we covered earlier, are not only risk factors for ME/CFS, but also for orthostatic intolerance and these biomechanical or structural dysfunctions. And by biomechanical considerations, we usually mean that symptoms can be provoked by application of a nerve or neural strain to the limbs or the spine. We're going to talk about the terms adverse neural tension or neural tension dysfunction, which are the terms used in the physical therapy world to describe these neural strains. We'll look at the data that we've generated on the prevalence of reduced range of motion of the limbs and spine in adolescents who have the illness. And I want to end with some work that we've been focusing on more, that neurogenic thoracic outlet syndrome can be a contributor to ME/CFS symptoms, and is something that is treatable, but not using the techniques that are usually familiar to ME/CFS clinicians. So our experience with this began with clinical observations in adolescents with ME/CFS, where we noticed an increased prevalence of postural abnormalities and movement restrictions. So this young man is standing in a way that his back is very kyphotic, curved, in this kind of way in the upper back. And his head is very far forward, not on top of his spine. So this requires much more energy to actually keep the head in that position than if he were standing straight up. We noticed that people had things like restrictions in the expected range of motion. So doing a straight leg raise test on the left in a healthy person, you'd expect the leg to get up well past 45 degrees in somebody who's got no illness problems. But on the right, you see that one of our ME/CFS patients could only get her leg to about 30 degrees before she got stretch and other symptoms that were bothersome. Here's that same individual showing that her ankle dorsiflexion, backward bend, was nowhere near the person on the left who is healthy. So this required a lot of physical therapy to get to the point where she could walk without excessive energy expenditure. Here's another patient, a young man who had a very limited prone knee bend. He couldn't get his leg up towards his rear end any better than this angle, which is less than 90 degrees and very abnormal. The other thing we noticed is that when patients went to their physical therapists and just had an assessment of their range of motion, they would get a worse period of fatigue afterwards. And we found that symptoms of the illness can be reproduced by putting mechanical tension on these nerve tissues. And let me show you how we looked at that. We did a passive straight leg raise, meaning that we held the individual's leg up for 12 minutes. And what we wanted to do was bring the leg to 10 degrees, let the person stabilize, measure their heart rate, blood pressure, pulse oximetry, skin temperature, and symptoms. Then we went to 20 degrees for 2 minutes, then 30 for 2 minutes, 40, 50, and 60. So the whole thing lasted 12 minutes. And then we put the leg back to the horizontal position. Our assumption going in was that something that the physical therapists were doing was stirring up the circulatory dysfunction that we knew was present in adolescents with ME/CFS. But what was interesting was that this was the response in one of the patients in our pilot study. So he came in with a fatigue score of 5.5 out of 10. And as we raised his leg further, by the 40-degree point, he was having worse fatigue, and that continued to the 60-degree point, and it even worsened in the time that we put his leg down. He had increased brain fog just from this maneuver. He had increased lightheadedness, even though lifting his leg should have improved the blood that was returning back to the heart and reduced the lightheadedness. So something else was going on. And he had some visual blurring. This young man needed a full hour to recover from this 12-minute test, indicating how prolonged the symptoms can be after a simple, relatively brief nerve strain. So we'll come back to this in the rest of the talk to see how we've explored this phenomenon more. But it seemed to me that if a simple straight leg raise could provoke this kind of increase in symptoms, it had to be an important component of what goes into the genesis of symptoms in this illness. So let's look at what we mean by adverse neural tension or neural tension dysfunction. Sometimes you hear the term neurodynamic dysfunction. So neurodynamics is the interaction between the nerve mechanics and nerve physiology. And the point here is that when we move around, as our bones and muscles and joints and connective tissues move in daily life, they transmit forces to the nerve tissues. And with movement, the nerve tissues have to elongate, slide, they have to angulate around joints like our elbow. And as part of that, they undergo some compression. We know from a variety of scientific studies that if you apply mechanical stress to the nerves, that can evoke physiologic responses. And these abnormal neurodynamic interactions initially were termed adverse neural tension, but people didn't like that term as much. And they used neurodynamic dysfunction or neural tension dysfunction. A lot of this work was actually coming out of physiotherapists in Australia like David Butler and Shacklock. So we know from cadaver studies and neuroanatomic studies that the nervous system has to adapt mechanically as we move. So as an example, the vertebral canal length increases between 5 and 9 centimeters from a full back bend all the way back to a full forward bend. The median nerve in the arm has to adapt to a 20% length difference between arm flexion and extension. And here's an example from a pioneering work by Alf Brieg, who was a Scandinavian neurosurgeon. And on the left, you see the spinal cord in a cadaver specimen with the nerve roots and the rest of the spinal canal being pretty slack. In flexion, however, here you can see the nerve is really tightened up as it's going out of the spinal cord. And all of the slack in the spinal cord has been tensioned up. The other thing is if you've got a physical stress that elongates that nerve, it's a bit like one of those little finger things that we all played with as kids, where the more you pull your fingers away, the tighter it gets. And that tensile stress can affect the way the nerve functions. So I put in here an illustration of this. And if you have ME/CFS, you might want to wait and try it later because it could provoke the symptoms I showed you earlier, including brain fog. But this, I think, is a nice demonstration of what we mean. Here's my wife as the model, showing that arm movement can bring on this neural stress. So if you have your arm in this position, usually you're not feeling any nerve symptoms at all. As you straighten it out, you've lengthened that nerve 20%. Most of us will get stretch across the area around the elbow. And if you lean your neck over to that side, often because you're feeding some slack into that tightness of the nerves, the stretch disappears. If you go the other way, the stretch increases, and it really increases if you put your hand down as she's showing you in this picture. So when you have abnormal mechanical tension within the nerve, then you get a protective increase in the resting muscle tone. So the muscle will tighten up if it senses that the nerve is being stretched because it doesn't want to allow further stretch and strain. But if you've increased your muscle tone, that increases the amount of energy that's required to perform that activity, and it reduces the ease of a certain movement. As you stretch the nerve, you get reductions in the nerve blood flow and the electrical conduction in that nerve, and you can get some edema or swelling within the nerve. All of that can increase the mechanical sensitivity of the nerves, and it can change autonomic nervous system responses like sweating or blood flow to the peripheral tissues. And more recent work has shown that when the nerve is under that kind of tension, you get release of inflammatory neuropeptides that can further cause injury or inflammation. So let's look at the evidence on reduced range of motion of the limbs and spine in adolescents. So we started this work after working with my colleague, Rick Bioland, whose picture you saw on the title slide of this talk. Rick has been a tremendous research colleague and clinical colleague with us for many years now. And we did this study with Colleen Marden when she was our research assistant and a number of our summer students, many of whom have gone on to careers in the healthcare professions. In fact, all of them have. So our study hypothesis was that compared to healthy controls, adolescents and young adults with ME/CFS would have an increased prevalence of restrictions in symptom-free range of motion of the limbs and spine, and an increased prevalence of symptoms that were provoked by our range of motion measurements. We did this study in our clinic, and it was a matched case control study drawn from participants who were in a 2-year cohort study we were doing, where we were treating them for their illness. And they were matched by sex because sex affects the range of motion of the joints and the hypermobility of the joints. And because of that, we wanted to have a control group that wasn't that had a similar degree of joint hypermobility to our patients to control for one of the key factors that influence range of motion. We measured hypermobility using the 9-point Beighton score, where if you have a score of 4 or higher, it counts as hypermobility. And we grouped the patients into categories where their Beighton score was 0 to 1, 2 to 3, 4 to 5, or 6 or higher. We were bringing in patients between 10 and 30 who met at the time, the Fukuda criteria for ME/CFS, and they were seen between 2008 and 2012. We excluded patients with prior depression or who had been referred by psychiatrists, assuming that their mental health problems were the primary problem preceding their fatigue. The controls were healthy adolescents who had to report good, very good, or excellent health. And we recruited them simultaneously over the 4 years of the cohort study. And we deliberately tried to bring in people who are expected to be more flexible. So children who are dancers, gymnasts, or swimmers. We excluded the controls if they had any overlapping problems. And everybody was excluded if they had a condition that was expected to interfere with the baseline range of motion movement. So if they'd had a recent fracture of a limb, prior surgery, developmental problems like cerebral palsy, or had been receiving physical therapy in the last few months, and any kind of arthritis or neuropathy. So the range of motion score that we came up with said, okay, for we're going to do these maneuvers: ankle dorsiflexion on each side, passive straight leg on raise on each side, prone knee bend on each side, prone press up, which you see in the bottom right, and a seated slump test, which we could measure on each leg, and then an upper limb neurodynamic test. And I'll show you these. Rick is demonstrating the straight leg raise here. You've seen the dorsiflexion of the ankle, the prone knee bend, and this is the prone press up. This is the seated slump test, which is designed to take all of the slack available in the spine and the peripheral nerves out of the system to really tighten the entire circuit. So here's somebody sitting, she slumps her back, she puts her head forward, and then she brings her leg as high up towards horizontal as she can. We record the symptoms, and then she brings her head up to feed some slack into that circuit to see if those symptoms improve. The upper limb neurodynamic test is a way of checking the median nerve excursion. So the patient is placed flat on the table. We keep their shoulder in position, rotate their shoulder, bring the shoulder to about 110 degrees, extend the wrist, supinate the forearm, and then bring them back towards the plane of the table, and then extend the elbow. And we're measuring how much the elbow can extend before they feel stretch. So when we did this study on individual maneuvers, we had, before the study, had defined an abnormal seated slump leg extension as anything less than 170 degrees of the leg coming up towards horizontal. Ankle dorsiflexion less than 95 degrees, straight leg raise less than 45 degrees, stretch in the arm before the 170-degree point for the upper limb tension test, and prone knee bend had to be less than 130. Prone press up we graded more subjectively as mild, moderate, or severe. And you can see that comparing the patients and the controls on all of these measures, on every measure, the ME/CFS patients had more restrictions numerically. The next slide shows you the numbers that were statistically significant. So 15% of our patients could not bring their ankle back more than up to the 95-degree point. On each side, they had much higher rates of passive straight leg raise strain, and the upper limb tension test was abnormal, at least on the right side. And the prone press up was suggestive of thoracic spine hypo or reduced mobility. And these are very high odds ratios in medicine. So these were significant results. On the right, I've shown you the graphic display of the range of motion score between our patients in the purplish color and the controls in gray. And the higher scores on this 11-point scale indicated worse range of motion problems. And you can see that the ME/CFS group was shifted well towards the higher end of the scale. And this, again, was a highly significant difference. When we looked at how people did over 2 years of treatment, both treatment of their other symptoms, their orthostatic intolerance, their pain, and often using physical therapy, but it wasn't a systematic study of physical therapy in all patients. You can see that as the time went on and as they improved, generally, their range of motion score also normalized. So this is not a fixed problem with range of motion. It can be treated. We found that more of our ME/CFS patients had abnormal symptomatic responses to at least one range of motion test. So that was 40% versus just 4% of the healthy kids. And more of them reported increased fatigue after the range of motion examination, similar to that pilot study we'd done earlier. So our speculation was that if a brief and relatively simple passive straight leg raise strain could provoke symptoms, then prolonged, repetitive, or excessive strain beyond the usual range of motion in daily life might be followed by a similar exacerbation in symptoms. And we've also felt that our clinical experience has been consistent with the notion that treating these areas of movement restriction before advancing to more aerobic movements might improve the ability of patients to tolerate physical activity better. And that's been a consistent observation by our physical therapists and ourselves. So to extend this work, we did a study with Kevin Fontaine and Rick Viol, and Kevin is shown on the bottom left. He was at Hopkins for a while, now at the University of Alabama at Birmingham. And this was funded by the Solve ME/CFS initiative. So we did a study in which we randomized 60 ME/CFS patients and 20 controls to either a true straight leg raise strain to induce neuromuscular strain or a sham strain. And this study had some important expectations. We were trying to determine whether, compared to healthy controls and to individuals who underwent this sham strain, participants with ME/CFS who had a 15-minute passive straight leg raise would report increased fatigue, cognitive dysfunction, pain, lightheadedness, and headache. So 5 cardinal symptoms during and immediately after the strain maneuver. And that they'd report elevated levels of the same symptoms 24 hours later. So this was a neuromuscular strain that was designed for each patient to be a bit different. We measured when they first felt strain as we lifted their legs up, and then we went to the end range when they wanted us to stop doing the straight leg raise, and we picked the point halfway between those two. So it was a good stretch, but not a painful one. The sham group had a less than 5 degrees supported straight leg raise for 15 minutes. So these were the ways we measured symptom intensity. It was on a 0 to 10 scale for each of those 5 symptoms. And then we added the scores up to create a combined symptom score. And then a secondary outcome was the proportion who reported a 2-point increase in intensity for any symptom. So here was the group with the CFS strain minus the healthy control strain. We would expect all of these to be significantly different, and they were for fatigue, pain, lightheadedness, trouble concentrating, headaches, and a total symptom score. But that's not a surprise to anybody. But what was more interesting was if we took the patients who got the true 15-minute straight leg raise strain, comparing their symptoms to the CFS patients who had this sham strain, we still saw significant differences in pain, difficulty with concentration, and the total symptom score at right after or during the procedure. And then interestingly, 24 hours later, when we called them back, they had an increase in their lightheadedness and their total symptom score, suggesting that this was a maneuver that could induce post-exertional malaise. Here's an example of the individual report for one of the participants in this study. You can see that lightheadedness at baseline was a 2. During the 15 minutes, it rose to a 4, and then kept going up to 5 immediately after the 15 minutes and at the 24-hour point. Concentration was at a 3 at baseline, and that increased up to a 6. Achiness or pain increased from 3 to 6, and fatigue increased from, 4 up to 6 by the end of the test. Now, when we graphed out the number of people who had an increase of at least 2 points in their symptom severity during the maneuver, the number who had one symptom increase by at least 2 points was higher in the ones who had the true strain. The ones who had two symptoms increasing by at least 2 points was also higher in the true strain group, as was the number with three symptoms out of the five that increased by 2 points. And this just shows the results at the 24-hour point, where the number having three symptoms increasing by at least 2 points was higher. Now, this study had some limitations. We were not blinding subjects to the degree of straight leg raise they were exposed to. So it could have been possible that patients reported biased symptom scores in the true strain group. We can't exclude that possibility. We also didn't extend the measurement period beyond 24 hours, so we can't make definitive comments about the duration of post-maneuver symptom exacerbations. And we didn't measure changes in biomarkers at 24 to 48 hours, but this would be important to do in future studies. The impact of the neuromuscular strain may have been underestimated because some individuals had symptom intensity scores at the 9 or 10 level, where we couldn't possibly identify a 2-point increase in their symptom severity. So that was on us as a methodologic limitation. Here's somebody where their fatigue was already at a 9. So there's no way, no matter how much you battered them, that they could get higher than a 10 score. So there's very little chance of being able to identify increased fatigue in that individual. One of our patients wrote back a week later after the end of the study, and she said, "Today's the first day I'm feeling better from the study, but I'm still not feeling great. I was in a lot of pain all weekend. My whole body hurt. I was exhausted but couldn't sleep. I wasn't capable of holding a coherent conversation or making decisions all weekend. Friday, I was emotionally unstable, cried a lot, also nauseated and couldn't eat. I'm still having more brain fog than usual." So this was an example of one person, at least, who had really quite prolonged post-exertional malaise after this very simple maneuver. So our conclusions were that a longitudinal strain applied to the nerves and the soft tissues around those nerves in the lower limb was capable of increasing symptom intensity for at least 24 hours. So these findings were consistent with our earlier observations that increased mechanical sensitivity is a contributor to the provocation of symptoms in this disorder. And one way in which this might be causing problems is if you take somebody and do a straight leg raise and do a measurement of their MRI, the lower part of the spinal cord is displaced about 3.5 centimeters. So it may be that by raising the leg, we're pulling this on the spinal cord and causing some tension within that within the spinal cord itself. The mechanisms for transducing or shifting that neuromuscular strain into increased symptoms aren't known, but they're neutral with regard to causal hypotheses about ME/CFS symptoms. So it could be that after an infection, say COVID, there's intraneural edema, that is swelling within the nerve that then leads to the tightness. There could also be immune-mediated changes that lead to the same problems in the nerves or in the central nervous system. It may be that our hypermobile patients are more at risk for this because their nerves have to really stretch to go around their hypermobile joints. And it may be that the problem is not so much in the periphery, but because of this deformative stress on the cord and being transmitted to the brain. So let's look at one other thing that we're focusing on in our more recent studies, and that's neurogenic thoracic outlet syndrome as a contributor to the systemic features of ME/CFS. So let me present a girl who we saw a number of years ago, but she came in with arm numbness, headache, neck pain, and fatigue. She had the onset of symptoms of 1 month after she'd been at a kids' camp in May. A month later, the arm and top of her head were numb after 10 minutes of swimming. The numbness would recur every time she tried resume swimming. So she stopped that, and the numbness got better. But a month later, it came back at basketball camp, and then it stopped when she stopped playing basketball. Her symptoms in the first couple of months were headaches, usually starting with the arm symptoms, then the headaches would come on along with lightheadedness when she was exercising. Then the numbness in the upper arm would appear, progressing to the wrist, and one side was worse than the other. So this would occur within 1 or 2 minutes. For example, she could do 10 or 15 jumping jacks and then would get this whole constellation of symptoms. When those symptoms came on, if she stopped the exercise, the numbness would last 2 hours, but if she continued, it would go on for 24 hours. She had a history of mild asthma. The general examination was normal. She didn't have any current asthma, and her cardiological evaluation was normal with a normal electrocardiogram and a normal echocardiogram. Lab results didn't identify a problem. She had quite an extensive screen looking for hidden causes of fatigue and discomfort. She was seen by my pediatric neurology consultants, colleagues here, and she had numbness that would extend from her biceps muscle to the wrist, sparing her hand. So they thought this was not really physiologic and might have been a manifestation of a behavioral problem. And some of that was because the young girl was a bit tearful and apprehensive when they examined her. But over time, her parents were appropriately worried about her reduced daily function and sought out another opinion. And the other symptoms that were present 6 months into the illness included neck pain on an occasional basis, but her arms would feel heavy, especially if they were up. She had headaches all day, every day that were worse with exercise. She was also lightheaded with exercise. She had enough daily fatigue that she was unable to attend school, so quite a substantial impact on her overall function. And when we saw her, her general examination was normal. She didn't have color change or swelling in the arm, which we look for as evidence of vascular forms of thoracic outlet syndrome. She did have a positive Hoffman sign bilaterally, which indicates nerve irritability. She was hypermobile with a Beighton score of 5. And on that upper limb neural tension test that I showed you before, she lacked about 20 degrees of elbow extension. She couldn't quite get to the full 180-degree extension point. She was missing 20 degrees on the left and 40 degrees on the right. When we did a standing test, she had a heart rate change that was consistent with postural tachycardia syndrome. And we treated her initially with an increase in salt and fluids, but that didn't make a major change in her arm symptoms. We tried some pain medication. Duloxetine is good for that, but that didn't lead to problems. She was very cooperative with physical therapy, but there were no improvements after a month, which is a bit unusual. And so based on her symptoms with her arms overhead, and that included the swimming and the basketball, and the positive Hoffman sign, we investigated her further for thoracic outlet syndrome. And when we see a positive Hoffman sign, we're looking for abnormalities in the cervical spine, but on the MRI, that was normal. Some patients with thoracic outlet syndrome have an extra rib coming out of the lower cervical vertebrae. She did not have that. But she did have a positive elevated arm stress test, which is also known as the Roos test. This is a picture of this test. The person has their arms in this candlestick position. They open and close their palms slowly over the course of 1 to 3 minutes, usually 3 minutes. And that was abnormal. Her ultrasound, which we look at to look at the flow velocity in the veins and the arteries, the flow velocity in the left axillary vein increased when her arm was taken backwards, indicating that it was being narrowed. And this difference in the velocity of flow is kind of like when you put your thumb over the end of a garden hose and you see the water streaming out much, much faster. Same phenomenon occurs with the ultrasound. Her scalene muscles at the back of the neck, through which nerves have to pass to get down to the thoracic outlet, were tender. when they put in a lidocaine block, an anesthetic block, she had an improvement in symptoms. And before the lidocaine, her elevated arm stress test was positive. She could generate numbness within just 20 seconds. And after the block, the numbness was better, and the arm stress test was negative at 90 seconds. So the thoracic surgeons and vascular surgeons who deal with this decided they needed to make more room in the thoracic outlet. So they took out part of her first rib and did some surgery on the scalene muscles that were compressing her nerves. And 6 weeks after surgery, she had a negative elevated arm stress test. So, and then several months later, she was playing basketball and volleyball for school, so she could now tolerate arm overhead postures and had no remaining symptoms. And as a result of feeling better, her mood was excellent. So thoracic outlet syndrome is caused by compression of the nerve and vascular bundles as they pass over through the space behind the clavicle in this area and over the first rib. So you can get one that involves nerve compression, you can get a venous form and an arterial form. And the causes can be congenital, as I was mentioning, from a cervical rib, from too much fibrous tissue. If you fracture your clavicle repeatedly, that can lead to some bony swelling and compression of that space. Repetitive trauma can do it, and as can overuse, as with overhead athletes. So pitchers in baseball, swimmers, and basketball players. So this is an overview of the right thoracic outlet to show you as the nerves are coming out of the spinal cord, they have to pass through the scalene muscles, which are pretty tight in the neck. They have to then go under the clavicle between it and the first rib. And that's why taking out the first rib can lead to some improvements in the degree of compression. And then under the pectoralis minor muscle. And so the thoracic outlet refers to this whole constellation of sites to get nerves and vessels down into the arm. This is a view from the front to show you a different image of the places that these nerves and vessels have to traverse. And the typical symptoms are paresthesias, which is a medical term for numbness and tingling, or weakness in the arm. And some people lose the ability to twist off the top of a jar. You can have associated pain in the head, the neck, and the trapezius muscles here, as well as the shoulder and arm. No single diagnostic maneuver is fully accurate, but the elevated arm stress test may be the most helpful. And along with lidocaine blocks, Botox is often very helpful in getting the muscle to sort of shrink its volume and not compress the nerves as much. That will only last about 3 months, though. So physical therapy is always recommended as a first step. And for people who have recurrent symptoms despite Botox and despite physical therapy, surgical treatment involves the first rib being taken out, either in part or in whole, and some kind of surgery on the scalene muscles. So we looked at patients that we were starting to suspect of having this, and we wanted to estimate the proportion of people with fatiguing illnesses who experience systemic symptoms during a common maneuver for thoracic outlet syndrome that you've just seen. And this was a retrospective review of patients we saw between January of 2020 and July of 2023. And in anyone who reported difficulty with arm overhead postures, they were evaluated with a 60-second or 1-minute elevated arm stress test. And we excluded those who'd had prior surgery on that region. So people sat in that position I showed you with their feet on the floor, and they just opened and closed their hands every 2 to 3 seconds for a minute. And we looked for local symptoms. We called it positive for local symptoms if they had pain, fatigue, heaviness, paresthesias, warmth, or tremulousness in the upper limb, shoulder, neck, head, or the upper part of the back. And we were also looking for systemic symptoms, which have not typically been part of what you read about in the thoracic outlet syndrome literature. If that person said, I'm more tired, I've had more brain fog, I'm more lightheaded, my heart is racing, I'm sweating, or I'm short of breath, or they felt hot or nauseated. Those were symptoms that were not attributable easily to the compression of the nerves in the arm. And so we looked at 154 new patients over that period of time. And of that group, 42% met the criteria reporting trouble with their arms overhead. Most commonly, we had to ask them, how do you feel when you're shampooing your hair? And as long as they had more hair than me, this could be the sort of thing that would give them arm fatigue or lightheadedness or discomfort. And of the 64 reporting that kind of problem, 78% had ME/CFS, 20% had idiopathic chronic fatigue, so they didn't meet all the criteria for ME/CFS, but they had associated orthostatic intolerance. So a lot of overlap. And then one person had chronic fatigue without orthostatic intolerance. Of that 64, 58% had evidence of joint hypermobility, which is thought to be a risk factor for thoracic outlet syndrome. We were able to provoke symptoms using this elevated arm stress test in 97% of them within a median of 20 seconds, so it's pretty quick. During that study, 41% reported systemic symptoms, most commonly lightheadedness and generalized fatigue. This just lists the local symptom responses. So what we were seeing was upper limb and shoulder fatigue in 67%, pain or discomfort in 52%, numbness or tingling in 38%, heaviness of the limb in 31%, upper back or neck pain in 11%, and other symptoms were less common. These were the systemic symptoms, so lightheadedness in 19%, fatigue in 11%, 6% had a racing heart or brain fog or sweating, and other symptoms were less common. This is a graph showing the time it took until they developed local symptoms. So this is 100% free of symptoms before they started. By 10 seconds in, 80% were free of symptoms, and by 20 seconds in, 50% were free of symptoms, which means that 50% had reported symptoms. And the number of reporting symptoms kept going up as we continued the test. So it's unclear whether the provocation of systemic symptoms and the higher sensitivity of this test are due to some other aspect of the overlapping illnesses, including ME/CFS, right? Is this just one more form of exercise, or is it truly a nerve compression? And it's possible that this involves a sufficient amount of exertion in people with ME/CFS that it provokes general symptoms as taking a long walk or trying to run might. So in future studies, it'll be important to enroll a comparison group with clear brachial plexus dysfunction, this nerve compression, but without ME/CFS, to look at how often they have systemic symptoms. So I think we've established that this is an underappreciated contributor to local and systemic symptoms. We find that manual physical therapy, as opposed to exercise-based physical therapy, is a promising method that's less likely to provoke PEM than exercise-based treatments. So I'm going to end there, just thanking those who've made our work over the last 30 years possible. We have an endowed chair from the Sunshine Natural Wellbeing Foundation that supports my professorship. We've had a number of families contribute to separate endowment funds that allow us to use the income on those endowments to support salaries. We've got a wonderful team. Renee Swope is our clinic nurse. Camille Broussard had been with us for the last 2.5 years as an adolescent medicine specialist, and she will continue collaborating with us on research. Dr. Alba Azola is a physical medicine and rehabilitation specialist who is supervising the care of the adults that are still in our clinic. And Megan Swope is our research assistant. Rick Violand is the physical therapist collaborator who's really helped a tremendous amount with the work that I've just presented you. And Colleen Martin had been with us as a volunteer research assistant for many years preceding the pandemic. We've had terrific summer students. Emily Steffensmeyer, who's standing with Rick at the bottom right, has done fundraising in State College, Pennsylvania on behalf of the clinic. And many families and patients have also contributed philanthropically to allow us to spend the amount of time you need to spend in taking care of the complexity of ME/CFS. And so we're entirely grateful to all of them for the work that we've been able to do and share with you. So I'm going to stop there. And our next talk will be on neuroanatomic contributors. These are uncommon, not affecting everybody, but important to recognize in patients who are, especially patients who are otherwise not responding to the other treatments. So that'll be the next talk that we give, and I'll stop there. Thanks very much.
At this moment in our program, we'd like to switch to a panel of those with lived experience with pediatric ME/CFS, who are now adults, who had child-onset ME, as well as a caregiver for that cohort. Our aim throughout this webinar series has been to provide a holistic impression of the child presenting the symptoms of ME/CFS. As with all lived experience panels, the patient population that you're about to see is not demographically representative of the population of ME/CFS. Also, although the panel does represent a range of severity of current and past experiences, the severity cannot be adequately noted based on a single interview. And our chapter is committed to patient equity. Let's get started.
Hi, my name is Denise Lopez Majano, and I'm a parent and a caregiver. For those who've been watching the series, you may remember me from the first episode with Dr. Rowe on manifestations of pediatric ME. My sons got sick at ages 12 and nearly 15, so things related to pediatric ME are especially meaningful for me. Over the years, and with Dr. Rowe's care and assistance, we've identified several comorbidities that my sons have, including neurogenic thoracic outlet syndrome. So I'm really interested today to learn more about the lived experience of our lived experience panel and their experiences with TOS and ME, etc. So welcome, Maritza and Kate and Lindsay, and thank you very much for being here with us and for sharing your experiences. This is really special. So could we start by each of you describing your journey to getting a diagnosis of TOS, like the age of symptom onset, age of diagnosis, etc., and how that played into the relationship of the TOS diagnosis and the ME diagnoses?
I first started feeling different and sick and chronically fatigued when I was around 14 years old, when I started high school. And I kind of had to fight through a ton of barriers to even get seen by anyone. And I would say it took about 6.5 years to actually finally get a full diagnosis. And to even get in to see someone to talk about ME is incredibly difficult. You have to see pretty much every single specialist out there to just check off all the other boxes. I mean, I was in radiology, I was in cardiology, I was in GI, I was everywhere you could imagine. And I had to switch in between peds. And then when I turned 18, I had to switch out of peds. And then I had to start the whole thing over again. And then I moved across the country to go to college. I moved from from California to DC. And then I had to start again. And so it really was about 6 years of fighting and getting turned away and people being like, yeah, there's something wrong, but it's not really in my specialty, so I can't help you with it. And it was really a defeating process and demoralizing. And I finally, like last ditch effort, went to Johns Hopkins and met with Dr. Peter Rowe. And I went in thinking this is just another going to be another one of those things. He's going to turn me out the door with nothing. And it's just that I know this and I was prepared for that. And I got in there and it was a 5-hour appointment filled with tons of questions and surveys and the whole thing. And I came out with like 6 diagnoses, all under the ME CFS umbrella, and TOS being one of those. That was a complete shock to me. Um, my whole family has EDS, Ehlers-Danlos Syndrome. And so I always thought that everything related to hyperflexibility, joints, that sort of thing was just kind of something my family dealt with and was completely normal. It hadn't affected anyone else's life, so why would it affect mine? And when Dr. Rowe said, you have TOS, I didn't even know what it was. I'd never heard of it. And I was like, I don't know that I'm feeling any of those symptoms. And he goes, you will. You'll figure it out. It'll hit you. And lo and behold, 2 months later, it became one of the worst things that I dealt with. So, yeah. And so I think that those 2 months were a combination of just the fact that it was just everything was snowballing so much. And then also I was coming to terms with this being my new reality, and I could kind of see it for what it was. And I think the validation of hearing of a diagnosis was also incredibly helpful, because medical gaslighting and being turned away for so long does affect how you think about what you're experiencing.
Well, Lindsay, how are you? And can you tell us something about your experiences?
Sure. I I actually, as a child, had Hodgkin's lymphoma, and then as a result of that, had various late effects throughout my late teen years. I was 13 when I went through treatment, but when I turned 25, my body just had this huge fallout of all the things just kind of collapsing, and it took a long time to get a diagnosis. So similar to what Maritza is saying, similar medical gaslighting, similar trips to all the different specialties, and finally finding the right people that would take me seriously. So I began a journey of treating the comorbidities sort of as they arose, whether it was that they were, well, I think that's fair to say as they arose, because for me, POTS wasn't like right away. It was maybe 3 years down the line after I was diagnosed with ME. And thoracic outlet syndrome was diagnosed a good when I was, now I have to do math. Let's see, a good probably 10 years down the line. And whether that's just when it was diagnosed, it had hit sort of a peak of symptoms, and I actually had it found by my hematologist, who's lovely and a wonderful practitioner. He was the first one that mentioned it to me. And it was blood flow issues. And some of that is convoluted by my history of lymphoma and radiation. And some of that is convoluted by POTS. And some of that is convoluted by ME. And some of that is apparently convoluted by thoracic outlet syndrome. So he was hearing me say like arms overhead and numbness in my arms, and I was having a lot of blood pooling in my head, and that pressure was really pushing on my trigeminal nerve and causing me very severe pain in my face. And so I was that became one of my most acutely painful symptoms. And it took quite a while. So I began the journey of finding a thoracic outlet specialist, which there are very few around the country.
And combine that with how few of them know about ME.
Yeah, it's taken a long time. So I've been getting therapy for TOS for about 8 years. Yeah.
Kate, can we move on to you?
Sure. Yeah. I was diagnosed with ME when I was 20, and it was about a year after a severe case of mono. Luckily, my mother was working at Johns Hopkins at the time, so she was like, "Who's the I spent 6 months kind of bouncing about like everybody else, and then luckily she was able to ask, who's the person here for chronic fatigue, and was pointed directly to Dr. Rowe. So that was helpful. I feel like I had a quicker diagnosis turnaround than most people, which I'm grateful for. Um, it the TOS wasn't something that was diagnosed right away, similar to Lindsay and Maritza. It was, but I think I probably had the symptoms. Like them, it seemed like when the symptoms started getting worse and worse and worse, that they were drawing my attention more. That's probably it was a few years after my original diagnosis, so like mid 20s. I thought maybe I was having so much pain and numbness because of just like being so sedentary, spending so much time in bed, having fibromyalgia, and just like the general myalgias that we experience. You just don't really know what is what. And just to add on to what the other lady said, I feel like we're always leaning into something and we're picking like a perspective to look at the umbrella of ME and how we're treating it. And for each of that's very individual. So I feel like you do kind of lean into to certain things at different times. And it feels like when one thing, like let's say you have a break from migraines miraculously for a time, and then everyone's like, okay, great, you're great then. And it's like, well, actually, now I'm very lightheaded. It's like the other thing pops up. So I think it was just one of those like symptom exchanges where it was like, okay, this is gonna, pop up more. And it's really interesting to talk to all of you to learn more about some things that might be TOS symptoms versus other things, and trying to kind of pull them apart in some kind of way. The one thing that I noticed is the TOS is more centralized in a location, or this is what I thought, because then you were saying about your legs, and I have numbness in my legs too sometimes. So
Really? Oh,
yeah,
you're the first person I've met that has said that they also feel that.
yeah. So I don't know what that is. I'm also being like like checked for other spinal things right now too. So I'm not really sure, but yeah, it seemed like it was more kind of isolated in this area. So it was like, okay, if I'm having like back pain or whatever, maybe that's not related, but you just don't know. I can't get a true sense of the full impact of it.
I think that's so true. I know in my son's cases, um, it was for one of them, it was 14 years. For the other one, it was 13 years after they got sick that we found out about the TOS. And that's with having, all of the care with Rowe for so long. But as he says, he's only become aware of some of these comorbidities during the time period that he's been treating us. So we can't fault him either. But yeah, and TOS is something that, Lindsay, I'm really pleased that you found somebody on your own who can treat you, because it's not really an awful lot of fun. And the arms overhead thing is something that a lot of people attribute to OI as being a problem. And yet we kept mentioning it to Rowe, and he said, and what exactly happens when he does that? So we would tell him, he cognitively wiped out. He gets this glazed look on his face. He can't talk. You don't want to ask him to make a decision for several hours, et cetera, et cetera. And he's like, yeah, I think we're going to evaluate him for TOS.
Interesting.
Really interesting that you mentioned that hands over the head thing, because so I have gotten to both surgeries for both sides for TOS, and part of that run through is you have to get an ultrasound for them to kind of measure your blood flow in the veins and the arteries and just kind of take a look at what's going on there. And they do it abducted and adducted, so your arm by your side, your arm above your head. And TOS, they're expecting that when you raise your arm, you get little to no blood flow. What's interesting is that that did occur for me on both sides. But what also was there was that even adducted, even with my arm down, still wasn't getting enough blood flow. So I think that that portion of it is more on the OI side. It's like you're not really pumping blood as efficiently and as productively as you should be. And then add on to that TOS, and you're just already starting negatively, and then it's just pulling you to the ground. And I think that in that way, you can kind of see it in the like minute details. You can see how they kind of interact with each other. But how would you really know that just by like living the experience? You really wouldn't. So that's an interesting thing that I kind of got to learn.
Yeah, that's fascinating. Makes so much sense when you have the data, right? It's like, yeah, blood isn't moving around, and then you like shut it off by putting your arm over your head entirely. It was just a trickle before, and now it's off. But it's also interesting, Denise, that you mentioned that your son feels like the glazed over inability to make a decision. I had not in my own mind. I feel that a lot, but I hadn't put it together with putting my arms over my head. So I'm going to pay attention to that in the future. I had mentioned when we were off camera or before we started that I've not met other people with thoracic outlet syndrome. So this is really special.
Really special for me because I'm learning an awful lot from all of you, and I really appreciate it.
Mm.
And I will relay things to my sons. So, I'm wondering, out of curiosity, how many of us, I'll include myself on the behalf of my sons, have EDS or HEDS, and whether or not that's a contributing factor as well.
I do not.
That's really interesting.
I do, and it sounds like Maritza does too.
Yeah, I will say how PT has to be altered based on our other comorbidities. EDS is one of those as well that you have to be really cognizant of, especially if you choose or are considering the surgery route, I will say. That was one of the things that I was like, okay, that's a con for surgery. If they take out your scalar muscles, that is less support for your joints that are already lacking support from EDS. And so you are at much higher risk afterwards to develop like cervical instability and things like that. And you really have to do your due diligence and go to PT 3 times a week, even though it's a lot of time. And it's so important to do the exercises on your own time as well. And, there are drawbacks, and you have to be very cognizant and aware of how your other things could play in. Because as we've discussed, the TOS expert is thinking about TOS and TOS only, and they're not drawing in everything else for you. So you do really have to advocate for your other things that you're concerned with constantly.
Mm-hmm. Well said. And I've also had some of my TOS practitioners tell me it's a negative to try to build those muscles because you're purposely trying to shrink them to get them off of the nerves and off of the blood vessels. Because part of mine was with blood flow as well as neurological. So it's just a real conundrum in that sense. Like, yes, with the EDS, you want to have as much strength as you can have, but managing the TOS is extremely important as well. And that like trigeminal nerve pain in my face like terrorized me that I'm like, that can never come back. Like that has to be gone. And it has been gone after a long time of doing Botox. But anyway, there's so many different things playing against each other.
So Maritza, you said that you had surgery, and Lindsay said that you're undergoing treatment for TOS. What sorts of treatments have you tried for TOS, each of you?
Um,
Yeah, go for it, Marie.
so when I first started, my symptom decline like got real bad. I immediately got into PT. Because they really like even if you get in with a TOS specialist, they'll want you to try PT as the first line of defense always. You're never gonna get to, I think Lindsay said that she's doing the Botox. You don't jump straight to Botox. Um, and I was with Dr. Lum. And so his kind of recipe is 6 months of PT before you start to talk about other treatments. So I did PT for around 2 months and it just, everything blew up. And they couldn't tell if it was the PT making it worse or whether it was just gonna be worse and worse and worse without PT intervention. But I mean, it was a very, like, it was a TOS specialist at Stanford. The exercises were totally fine. And so I did do that and it made it so bad. And so Dr. Rowe reached out to Dr. Lum and I went back to school in the fall and saw him right in September. And we just kind of like went through very fast tracked because of how severe my symptoms were. And I really couldn't function in my day-to-day life anymore. I mean, I was like a puddle of tears returning back to school because I was like, I can't do this. Like I can't even like open a water bottle anymore, because your grip strength goes, you know, you lose like all of these normal things, and that's what drives you crazy because it's like those little things add up and it's constant throughout your day. And it's like as if you were like stubbing your toe every 5 minutes. It just gets to you. And then so I just didn't want to go. And I saw Dr. Lum and I was like, if I don't get treatment for this, I have to take off school. I can't do anymore. And luckily he completely validated everything and he said, we can do Botox, but I have mast cell. And that's something to consider. Botox is a toxin that is injected into your muscles. And I mean, when I get a flu shot, my arm like enlarges 3 times its size. So I was really wary to, try Botox, and that's every month for pretty much the rest of your life, unless something magically happens where you can kind of lower the amount of dosing. And I was just really scared of it. And I was like, I just don't think that's going to work because that would send me into a week of heightened mast cell episodes. And so then I would really only have 2 weeks of relief and then I'd start the whole thing over again. And so for me, surgery was just seemed like the way to go. I needed that completely gone for where I was in life.
Now you say surgery, was that the rib resection?
So yeah, that's the other interesting thing about
Okay.
surgery is they can't exactly tell you what's going to happen. You know that you're going to get the rib resected. That's the base minimum.
Right.
But you can't see nerves on the imaging on ultrasound. So they don't know what they're going to find when they get in there. And so they kind of say, okay, there's a chance you're coming out with, they're going to take your scalar muscles out too and carve away to make room for the nerve depending on what they see. And so for me both sides ended up I had to get 2 scalar muscles removed from either side, um, which made the surgery longer. So my surgery was about 3 hours each side, and my right side ended up being really complicated and there was a lot more disruption that had to be done. And so you know it's kind of a surprise. You don't really know what you're going to get. Thankfully, Dr. Lum was incredible.
Interesting. How different factors play in and how it's such a trial and error in terms of treatment and what works and what doesn't work. For me, I ended up at Mass General to see Dr. Donahue. And because of my Hodgkin's history, that's really why I can't do the surgery is it would be very dangerous. It's not that I can't, it would be very dangerous because it would be very difficult to be able to see the difference between muscle and nerve. And once he's in there, apparently he had a long explanation as to why that would be the case. So I was kind of, my only option was the Botox. And it's been an interesting journey with doing the Botox. In the beginning, it really only, it definitely to this day flares me for a good week. That's 100%. But in the beginning, the benefits would last only maybe the best case scenario, like 5 weeks of the 3-month period that you can go. You're eligible to get them every 3 months. And yet over time, your muscle, the idea is that the Botox shrinks the muscle and gets the muscle off the nerve and off the vessels. So over time, the way that the muscle shrinks, it shrinks permanently if you do it longer and longer and longer and longer. So when you're at like 8 years, like I am, I can go longer in between. And I feel fewer symptoms because those muscles are so small, because I've had repeat Botox in them. But there is a trade-off in that there becomes a point where the radiologist can no longer see those muscles. And when that happens, you can't get Botox anymore. You've like had a lifetime cap because they turn opaque, they turn like bright white on the ultrasound machine. And so they can't see what they're injecting into. And because it is a toxin, they can't be sure of where it's going, is how it was explained to me. So that is a risk for me always. And so now I just am at a place where I'm trying to like stretch out in between, like how long can I go? Because it doesn't matter, like if I were to hit that threshold of I've had all the Botox I can have, or let's say the muscles are opaque. It doesn't matter if I wait a year, like it doesn't get better. They're still that way. So I'm trying to stretch out in between, like how long can I go? And the most I can go is like 4 or 5 months. And then I found that the next round doesn't last as long. Like if I stretch out this round to 5 months, the benefits of the next time aren't as long. It doesn't work quite as well as it did previous, like if I kept it at the 3-4 month range. So, but I feel much better than I used to for having done the Botox, and now I can go a lot longer and with far fewer symptoms. But like Maritza said, it still impacts, like I'll have bad days, and certainly, and it affects grip strength. That was when you said that, I was like, right, like chopping vegetables or like holding onto a knife and trying to cook is like sometimes can be just impossible.
Try holding a hand mixer. Oh my gosh.
Yes.
Don't even think about it.
Right. Yeah.
And actually, one of my sons did get one Botox treatment, and it helped him for about 40 days. But keep in mind that the first 10 days of that, he was crashed because we had to go from Pennsylvania to Baltimore to get the Botox because we couldn't find anybody in the area who could give it to him. And for him, those benefits were really nice, and he really appreciated them and would have loved to have continued doing this, but it's not a long enough period of benefits to outweigh the preemptive rest before an appointment and the post-exertional malaise after the appointment.
Mm-hmm.
So Botox at the moment isn't an option for him.
I have such a hard time chopping vegetables, and I didn't realize why.
Yeah, it's the gripping
Oh,
knife.
And it's really interesting. The PT post surgery is very like it's heavy on grip strength rebuilding. And it's so crazy. Like the exercises that you can do that builds it up and they seem so stupid. Like it's like you're holding a band and you're just going like this. But it's so difficult. Like if anyone else were to do that, they could do it with such ease. And I'm sitting there and I can barely like move the bar. And I had to have pliers and a wrench in my kitchen utensil drawer at all times because I couldn't open a thing and I couldn't maneuver my way around anything in there. I'm a college student. I couldn't write as fast as other people because I couldn't hold a pencil very well. My hand would get tired. So everything took me longer. I could never get the notes down like while the slide was up. So there's just little things over and over and over again that you just can't escape.
Yeah. What other sorts of what are the sorts of benefits have you noticed, Maritza, from the surgery?
So I guess I haven't fully like listed out some of my symptoms before. Um, some of my really bad symptoms that, again, I couldn't really attribute directly to TOS before, but now the surgery has kind of allowed me to look back and reflect and be like, oh, that was exactly what TOS was. Um, so one of the worst things, it became one of the worst things, was vertigo. It was so bad. Everything TOS for me was occipital, so I know that Lindsay's was very trigeminal. I had some of the trigeminal too. I had facial drooping and muscle weakness due to that, but most of it was occipital. I had really bad occipital neuralgia, visual migraines pretty much every night, and so my vertigo was also very visual, and I would be sitting in a classroom and the entire classroom would flip. And so it would look upside down to me, so I couldn't read a board. Sometimes I would be sitting in a chair and like slowly go like this and feel like and I would actually fall out of my chair sometimes. So vertigo was really bad. I would go to school in DC in the city. Escalators, elevators kickstart your vertigo really bad. So I was in this weird place where even like going to class, I was like, okay, do I take the stairs and have my heart rate jump to 180 BPM and risk like fainting, falling back down the stairs? Or do I take the elevator and risk, falling over on somebody in the elevator? And, I couldn't take the metro because I was like, there's so many escalators. It was like dangerous. And so it was horrible. The vertigo was awful. Um, and it was really hard for me to separate from POTS at the time because I was like, okay, well, maybe it's just, a form of that and fainting, but it was TOS. And having since the first surgery, it went down a lot because my left side was so much worse than my right symptomatically. What they found inside was that the right was worse in terms of what it looked like in there. Um, and now I'm about a month and a half out of surgery from my right side, and now having both done, I mean, I've had one migraine in the last month and a half, and my numbness tingling is pretty much absent all the time. I can lay on my side for the first time in years without everything going numb. My brain fog is so much better. People don't like that's one of the hardest ones for me still to this day to dissect between POTS, mast cell, everything is brain fog. Because I mean it's under all of them. And, also the name of the game in chronic fatigue is symptom management. So you're not curing this med isn't, oh, this is going to cure POTS. This is going to cure mast cell. It's like, no, this is going to help you with your brain fog. This is going to help you with flushing. This is going to help you with blood flow. And so it was really hard to dissect that. But I will say, like, all of that has improved significantly. I think if anything, I still have brain fog because of the other things at play. But vertigo, I haven't even had a single episode of vertigo since the surgeries. So, I mean, it's an insane difference. It really is.
I was struggling a lot before getting treatment, and I would say it has definitely taken one avenue of suffering and pulled it way back. If that makes any sense, my analogy. Um, it doesn't fix the other avenues. It doesn't touch necessarily the other ones at all. But this one that I was really struggling with, I would say and even that like has all different branches off of it. Like the face pain that I was having that was so debilitating, that's like 90% better. But the arm functions and the grip strength, I'd say that's like 50% better. Depending on where I am in the month or the cycle of the Botox. But I would definitely say that the treatments have had a significant impact on my TOS symptoms.
So you bring up an interesting point, and that is something I would like to emphasize, that none of the treatments, none of the options that we've discussed are a cure for ME. We're talking about helping a portion of what the whole is part of the whole picture that each individual experiences, and each individual experiences them differently.
Mm-hmm.
So
For me, I think that I had a different experience with treatment than both of you. So I think it's good we have some diversity in the way that we've approached it. I think that mine hasn't gotten to the peak where it's like ever like the primary symptom, but now I'm like, maybe it is the primary thing. I don't know. And it felt like we were kind of treating it along with other things. Like for instance, I get Botox for migraine and I do get like injections down my neck and shoulders. So I wonder if that, could be helping. And then just have been in and out of PT for so long. And actually the big issue I had with PT is I didn't see a thoracic outlet specialist for PT. It was more like help her with like migraines, neck pain, tension, like those kinds of things. And also thoracic outlet syndrome. And whenever I would try to bring it up to various PTs that I've seen who were very good otherwise, it was like nobody wanted to talk about TOS. Nobody wanted to, they were like, well, like the exercises you're doing pretty much cover that too. But never like really looked into it or explained it more. And it was very much like there's a lot of stigma. There was a lot of stigma around it. Because I think you walk in and you're like, I have ME, I have fibromyalgia, I have chronic migraine, I have like all POTS, all this stuff. And people are like, let's talk about the POTS. I I know what that is, or whatever. So I think that the stigma really gets in the way of the treatment, and it's horrible. And I just want anyone listening to know that like we're all experiencing this, and like don't give up. Make sure you advocate for yourself. I had a therapist who I got to a PT who I got to know really well, and eventually she was like, honestly, Kate, until I met you, I didn't believe ME was a real thing. And she's like, now that I've met you, I understand. I thought it was just like, old women coming in here complaining. That's who we are as a community, apparently. And so one of the things I do, and you shouldn't have to be an ambassador for ME, is that anytime there's like a student in there shadowing the PT, I'd always be like, hey, bring that student over here. It's like, have you heard of ME before? And I would just like talk their ear off and I'd be like, look, this is like the PT that I'm getting. These are the issues I'm having. And this is what complicates it. Like, I can't do this exercise because I start to black out. Like, I can't do this because I get dizzy. I can't stand up. I have to, and just trying to like educate and just like hoping that people can be more educated and better serve you, but just know that you're not alone in struggling through this.
So Kate, where do you come down currently on, you said that you're looking into other things that may take priority over any treatment for TOS, but are you thinking about TOS any differently today?
Yeah, for sure. Like a lot of the things, like I said, we can't, it's so hard to dissect and pull things apart from each other. So a lot of things that Maritza and Lindsay and that you're saying are really resonating with me. And I'm realizing I'm, even just I have two children and I read to them every night. And my son, who's 3, he likes to like cuddle up. He wants my arm underneath of him. Just imagine this. He wants my arm underneath of him, like holding him, and then the book up. We're both laying down and reading the book, and I have to like be like stretching my arm, my everything's going numb, and then I'm like, hold on, can you just move there, and like I'll just use my arm, and he's like, cuddle, cuddle. I'm like, oh my gosh. So we have like we stack up stuffed animals to like hold the book and hold my arms and prop, like just to be creative. And I think about that all the time. I think about it when I'm reading the most, because it's just such an awkward position. Sometimes also like just raising these two kids is like, sometimes I can pick them up and sometimes I can't. I'm like, I'm gonna drop you. Mommy can't hold you right now. I will drop you. Like I can't grasp you. But like let me sit down and you can sit on my lap or whatever. But we have a lot of arguments about like you have to walk. I cannot carry you. I also cannot push you in a stroller. You're like over 30 pounds. We have to, you know, um, so just trying to like be creative in my life, but hearing what you all said today, there's a lot of things that are resonating with me and that I hadn't thought about, like the cutting of the vegetables and leg symptoms and just I don't know. It's a lot to like consider more.
Mm. Parting thoughts?
Thank you for the opportunity to speak about this. I've never been asked before, and I just about it much, and I just think it's a wonderful opportunity for sharing and meeting one another. That there's just thank you so much for the opportunity.
To anybody who's on either side of it, if you know somebody, if you're a doctor taking care of somebody, just really try to like hear people for what they're saying and understand them for what they're saying to the best of your ability, and take the person as the whole person and not just a sector of them. Because, our bodies are organized very complexly and not everything is, one and one and one and one. So I would say be kind to yourself, be kind to everyone else around you. Yeah.
Thank you, and thank you for using your energy for this, because I know this isn't easy for either of you.
Yeah,
I
I
really
have to
appreciate
say,
it.
this is like an incredible thing that you guys are doing, and it's so important.
Thanks everybody for participating in our panel. We deeply appreciate you. Thank you to Dr. Rowe, and thanks again for viewing Biomechanical Considerations of Pediatric ME-CFS. Watch all of the episodes in Evidence-Based Pediatric ME-CFS webinar by Dr. Peter Rowe on youtube.com at MEAct Maryland. Please bookmark and share with your colleagues. Our next presentation will be the 5th and final of the lecture series, Neuroanatomical Considerations of Pediatric ME-CFS. This will be followed by a capstone Q&A presentation. Please email your questions for Dr. Rowe or for any of our lived experience panelists at maryland@meaction.net. As noted, our next presentation is on neuroanatomic considerations for pediatric ME-CFS. We'll see you then.